told I have to stand on stage so the microphone can transmit to our colleagues in I think Blackrock and Limerick. So if I move off the podium, let me know. I have a habit of wandering. And okay, mortality, to measure or not to measure. So I think this is something that's probably particularly relevant to palliative care. And I became involved in mortality data measurement almost 2 years ago now. And I came from a position, I was a clinical director at the time, and there's lots of data in the system. So I'm going to share some of my own thoughts, look at things from a historical context, what mortality data has driven in healthcare and some of the changes it's driven, and perhaps ask the questions how we should use mortality data in 2017 going forward, and whether it can help improve the quality ultimately that we provide to all our patients. I suppose in terms of a declared interest, I am the National Clinical Lead for National Audit of Hospital Mortality in Ireland, so I probably have a bias towards supporting mortality data. Does anybody recognise this? It's for our colleagues who are not sure if they can see this online, it's a picture of a pump.
London?
Okay, it is London. We've got the city.
Snow? No.
Okay, so top marks to Pauline. It's a Broad Street pump in now known as Broderick Street in Soho in London, which John Snow, who's been credited as being the father of public health, looked at mortality rates from cholera in 1854 and was able to determine that the cholera outbreak came from one water source, and the Broad Street pump, which is still there. So I suppose this is probably one of the earliest, arguably one of the earliest interventions of using mortality data. And that's John Snow. This is the General Hospital in Vienna, where Semmelweis worked, and Semmelweis was a surgeon actually who worked there from 1840, and he noted that the death rate for maternal mortality from sepsis, puerperal sepsis, was in the order of up to 30%. 1 in 3 women giving birth died, and he started collecting data to try and understand why this was, because it was different to other centres. Now, unfortunately on this slide I've lost my Y and X axis. The Y axis are the percentage points, so each horizontal line is 5%, so you can see at one stage, I don't have a pointer, that's alright. Each percentage point is, each on the side axis, the maximum point in that graph is about 30% mortality. And when they brought in hand washing, particularly for the medical students, you can see that the mortality rate reduced to below 5%. And this was a subtle piece of work which wasn't identified at the time, and actually he ended up being discredited and died in an asylum 15 years later. And I suppose this work is all the more remarkable in that germ theory and bacteriology was not understood at the time, and this was from looking at mortality data. He looked at 2 clinics. One was a physician-led clinic where they had medical students, that's the one in pink, and he looked at another clinic was led by a different physician who tended to have midwives working with him. And you'll be delighted to hear the midwives obviously washed their hands, and they had a lower mortality rate. And where things started diverging was on the vertical line on the left. That's when they brought in anatomical teaching, where people were handling pathological specimens, which prior to the days of formalin and so on. So there was bacteria being transmitted from the dissection rooms to the medical students, to women, and hence the high rate of sepsis, which this didn't affect the nurses. And when they brought in hand washing, you can see, and this is interesting when you see a change. Initially there's an excellent response, and then there's a bit of drift, and for those of you interested in change management, this is a well recognized phenomenon. What I didn't know when I was looking into this 2 years ago was that he compared his data to the Dublin Maternity Hospital. So the Dublin Maternity Hospital, aka the Rotunda, has been recording data since the 1600s and had shared its data internationally in publications, and was accessible. And this was the only comparable data he could get at the time. And interestingly, even though in Dublin teaching was based on the medical student teaching was based on the dissection room as well, that their mortality rates from sepsis didn't change with the introduction of anatomical teaching, or and hand washing didn't make a remarkable change to that either. So it just shows the different practice. So moving slightly forward, maybe a year or two, from the 1840s to the 1850s, Florence Nightingale, who was appointed as the Nurse General for the Crimean War in 1853, had, I suppose, again, an interesting background. She was homeschooled by her father, who was a university academic, and it was said at the age of 12 she had completed the equivalent of a degree in statistics in terms of in her homeschooling and mathematics. She brought this knowledge to looking at mortality rates in the army, and she compared the death rate of the army during peacetime with the civilian death rate and found that the army had a far higher death rate. And this was due to the squalid conditions that soldiers were living in and the poor healthcare facilities that the army provided for treatment. And she coined the phrase, "Our soldiers are enlisted to die in barracks." There was a Royal Commission on the health of the army. Contentiously, she started producing league tables, which I'll come back to talk about how they are contentious. And she worked with William Farr, who's probably the father of what we know as biostatistics. And they looked at reforming hospital statistics and also public health in general, looking at the design of large conurbations and social housing and how bathrooms should be, sanitation should be outside of the house and so on, and arguably significant changes in the health of the population. And his department was originally called the Applied Maths Department, or Applied Statistics Department in Oxford, was renamed Biomaths Department in 1988. And for those of you that are interested in a bit of light reading, Florence published a book, Notes on Matters Affecting Health, Efficiency and Hospital Administration of the British Army in 1858. It's a weighty tome of 850 pages, but it shows that actually people have been using statistics to improve the quality of care and reduce mortality for a long time. This is one of the graphs produced by Florence Nightingale in her publication. This is a polar area graph, and in simple terms, the surface area that you see here for each of the domains is proportional to the to the mortality percentage. The slices of the pie are the different months of the year. So I think the striking thing for this is that contagious disease in the 1800s was the leading cause of death. Even during wartime, and if you can see, it doesn't project very well, perhaps more the pink or red area are people who died from wounds in battle or wartime related injuries. It's much smaller than contagious disease. So also looking at mortality, we can see that looking at infant mortality, we've seen a huge change in the developed world in the last 100 years. And we can also look, if you look at the inverse of that in terms of life expectancy, we've seen life expectancy essentially double in just over 100 years. So the challenges of mortality data, as I said, we are literally awash with data but short in information. And this is probably, I think, for all of us where we struggle in everyday life and with reports and performance indicators and different data arriving on our desks, is trying to separate the signal where there's a real message from the noise where there's aberrant messages which are probably not significant. Measurement of healthcare is complex, and for those of you who think there is one indicator that we can determine quality of healthcare, the bad news is there isn't. It's going to take a number of indicators. And this has been shown in the Mid-Staffordshire reports and the Bruce Keogh's review and the Francis Inquiry, that actually hospitals, even the worst performing hospitals, will always perform well for some quality measures. So we need a suite of indicators. A multi-dimensional approach is needed as well, and that's something we need to be careful about. I think we're starting to move towards patient service user outcome based quality measures as opposed to the outcome measures that relate the activity of the service. We all tend to think of how our service is running and how busy we are as opposed to what's happening for the service user. How are they benefiting from the care, the treatment that we provide? I think where some of the pitfalls, and I'm reminded of an article I saw in the Irish Times 3 years ago where they published the crude mortality rates for hospitals and used that as a bona fide comparison of quality between hospitals. And I think we'd all appreciate that crude mortality data is just that. And it has no reflection on the complexity of cases, the case mix, whether you've got, if you have a tertiary referral centre, such as a transplant centre, the likelihood is they're getting much sicker patients with that disease entity, and the mortality rate may be subsequently much higher. So crude mortality is helpful on a national perspective. I would argue on an individual hospital perspective gives very little data. You need to, I suppose, drill under the surface and look at the complexity of care and the variations with that. Case reviews have been, I suppose, postulated by those who argue against mortality data are more reliable. They're not. They are useful, and I would argue they should be used. I think, in fairness to our surgical colleagues, I think they're years ahead of us in doing morbidity and mortality meetings, and there's a culture of, if you like, open discussion around cases and how things could have, in retrospect, how will we deal with a case like this again, where there's an issue where they identify where care was substandard. I think we're in an era now of where gaming, so people will look at data, and I remember when we started publishing waiting lists for hospital outpatients just over 10 years ago, even at that stage there was gaming. So you weren't on the waiting list until somebody had opened the referral, read the letter and put soon, urgent, routine on it. And some hospitals, and it's a matter of public record, stockpiled letters and didn't open them so that people wouldn't be on waiting lists and so on. So we need to be, I suppose, and this is where I think integrity is important. If you did this in the financial sector, well, in some countries you'd be locked up, in others you might be clapped on the back. But I think this doesn't help anybody in the long run, and I think gaming has probably discredited our attempts at quality data and quality measurements. Clinical audit data is useful, but it tends to capture a single episode on a patient journey, and usually a process measure, as opposed to an outcome measure. And I think a lot of audit data, I think, tends to capture processes which are important or of significance to the hospital system and are of arguable benefit to the patient. Which debts to count? This is something we encountered early on. So in Ireland we still don't have a unique patient identifier number. So if a patient moves between 3 or 4 different hospitals, we're not able to track that patient. They come up as separate admissions in each hospital. So there is difficulty with that. And because of that, and that's one of the deficits with our mortality data, which I'll talk about at the end of the presentation, we're not able to monitor patients who die after an episode of care in the hospital, because arguably that's an extension of their care episode. We're not able to capture that. That's a big deficit. We're told our unique identifier is imminent, but we do need it to be able to follow care. And I think it applies in palliative care. I know with our own minimum data set, we have difficulty tracking patients who, let's say, get referred to a home care team in one region, a hospice in a different region, and a hospital-based specialist palliative care team somewhere else. They come up as separate patient episodes. We're not able to cross-tally to identify those that they're the same patient. Albeit if they're in the same region within a specialist palliative care service, it may be possible, but if people move, they end up as being counted as separate patients, even though it's the one patient. Which hospital should the debt be attributed to? And this has become, I suppose this is again a product of modern healthcare, sophisticated healthcare. Perhaps it's timely. I work in a hospital at the moment where there's a contentious issue around 24/7 PCI care for non-ST or ST elevation MI. And so if a patient comes into our hospital out of hours, is blue lighted to the nearest PCI centre, and if they die subsequently, that debt will be registered in the hospital, the second hospital that they're in. And we can't connect that to the episode of care in the first hospital. So we need our unique patient identifier. So these are some of the problems we have in our system, and that we're working around. Coding. I would say overcoding in an Irish context, in fact I'll I'll be contentious, overcoding in our public hospitals is not an issue. Our coding is generally where we tend to have the principal diagnosis of one or two things. We don't tend to code well, and that's because there isn't an emphasis placed on it. In terms of hive coding, it's usually taken from discharge letters, which are often done by the most junior doctors in the hospital, the interns who may have been in the job a week, a month, a few months. Nobody's ever coached them or gone through the different types of code. So if you have a patient who comes in with a lower respiratory tract infection, they score X points on a coding system in terms of complexity of care. If they have uncontrolled diabetes, that complexity of that care episode will be weighted further. And if they have a episode of an acute kidney injury, again there'll be further weighting on that. So coding is an issue, and that's the data we rely on for in terms of generating our reports. I suppose again, somewhat unique to the Irish system, we have a lot of compared to international norms, we have a lot of small hospitals providing acute care. And one of the challenges around this in small hospitals is that they may have a small number of deaths from certain conditions, which means that one or two deaths may swing the data, so you have to be very careful around reading the significance of mortality data into that. And maybe just to highlight one area that we're working at the moment with Tim MacDonald is the COPD. So COPD coding is very difficult. A patient dies from COPD. Do they die from the lobar pneumonia? The 12 different types of lobar pneumonia that are described in the ICD system, ICD-10, do they die from their COPD? So these are some of the things we're trying to tease through at the moment, have some consistency in coding, and that we can attribute, have accurate mortality data. Some of the controversies, again, this is just a clear, this graph slipped from one slide, this are child mortality rates between, if you like, the developed world and the developing world. But I suppose the positive news from this is that child mortality rates are decreasing everywhere. Obviously, you'd like to see a little more convergence on the right-hand side of this graph. The palliative care code. So in some countries where mortality data, I suppose, is more established, namely Australia and the US and Canada, palliative care, patients who are coded for palliative care, and I'll come back to what that means, are excluded from mortality data. When I became initially involved in this, I had a huge concern about this, in that it was a bit like saying there's nothing to see here, and if a patient has been seen by palliative care, that's an expected quality approved death, and we don't need to look at these cases. And I was very uncomfortable with that, so we changed our Irish system to include palliative care patients as part of our analysis of mortality data. Risk adjustment. This is complex, and this is where, on simple perspective, you would look at risk adjusts for age, sex. We have a poor deprivation index, the medical card, which with non-means tested medical cards is a poor indicator, but we use that. We use the type of presentation to hospital, whether it was an emergency presentation or not, whether they had other emergency presentations within the previous 12 months to hospital. We use the Charlson Index, which is looking at comorbidities, again, which is a predictor. You can helps you stratify in more detail and more accurately your likelihood of mortality from for that individual patient episode. And it's important that we focus on true measures of quality. Smoke alarms, what I mean by that is, and again this is to do with what I talked about, signals and noise. The last thing any of us need, and which we often have to deal with, is false alarms. We've all worked in a building where the smoke alarm went off, somebody had the toaster in the kitchen, and it gets to the stage where people ignore it. And someday there will be a fire, and nobody will listen to the smoke alarm. It's like car alarms in the late 80s, early 90s. After a few years, we probably don't even hear car alarms in the car parks anymore. We ignore them. And this is one of my concerns about triggering signals, that we need to be very sure that that signal is a signal and isn't noise, because if you cry wolf too often, people lose interest and won't engage with the process. Preventable deaths. Now this is comes with a government health warning, and there's a lot of subjectivity here, but when we analyse mortality data, probably about 1 in 20 cases, when they're looked at by independent clinical review, looking at case notes, are potentially preventable deaths. So it's a relatively small percentage, but important. I mentioned the Bruce Keogh's review and the Francis inquiry regarding the Mid-Staffordshire issues in the UK, where I suppose perhaps the cliche that captures it best is that they were hitting the targets and missing the point, that they were hitting some of their process measure indicators, but overall there was huge deficits in their basic care and to patients. So both those publications supported the use of using multiple metrics that capture the quality of the patient episode, looking at process measures and outcome measures. Okay, so again, this is a somewhat busy slide. This is what I mentioned earlier. If you maybe shoot down towards the fifth or sixth from the bottom, you can see palliative care is included in ours, but you can see in a number of the mortality data models around the world it's excluded. And some have changed. 2 in the UK have changed recently to include them, including the Dr. Foster. Excuse me. And most of them use similar models to ours in terms of regression analysis, in terms of predicting likelihood of death in risk adjusting for certain illnesses, admission rates, and so on. So can hospital mortality data cause harm? And yes, it can. So there can be institutional or damage to reputation. If the media report something in error or report a signal as indicating that there is poor quality of care, or a hospital has excess deaths, implying that they're preventable deaths. So it's important that mortality data is used accurately. Conflicts of interest arise, and this is probably tied into gaming and how people use the data, and it's been shown in the UK and Canada when mortality monitoring was introduced, that the referrals to palliative care went way up. Now, I'm not saying that was to take those patients out of consideration, but it was interesting that the timeline seemed to be cause and effect. And I think sometimes, as I say, what we don't want to do with any quality measurement or with performance measures is distract hospitals from real quality issues. And perhaps use some examples around process issues just to clarify with that. So process issues are things like waiting time for outpatients, waiting time for a scope. It's to do with your processes. Outcome measures should reflect patient outcomes, patient well-being, patient mortality being a significant one, and so forth. So as I said earlier, you need both sets of measures in a healthcare system to monitor your performance. How not to use mortality data. So I think at this stage there's enough evidence and experience around the world to suggest that league tables don't work. There's a number of reasons for that, which I'll talk about with our own data, but perhaps the most important one is that you cannot compare different hospitals in that. And it's one of the things I used to hear going around the country with, when I was meeting clinical directors, is that our hospital is different. We're all different, but actually every hospital is a little bit different in terms of its age profile, its cohort, referral patterns, how patients might access care, whether there's community intervention teams. I suppose the impacts of the macro system. So for instance, looking at the palliative care analogy, if there's availability of hospice and good access to community supports from palliative care, community support beds, that may reduce your hospital mortality, because correctly you can discharge patients who will die in an appropriate place of care, compared to centres where you don't have access to those services may artificially increase your mortality rate in the hospital. So these can all have an effect. You can't attribute all deaths or excess deaths as being preventable, and I'll talk about how how an analysis should be done to determine that. You can't assume that low or within normal limits mortality figures suggest high quality care. And one of the things I've been promoting is hospitals that have high mortality rates should be looking at their data, and we have a system where we buddy them up with similar hospitals with low mortality rates a little bit of learning. What are they doing different here? Is there different processes and so on? Hospital processes are never the sole determinants of mortality rates. And there can be sometimes, as I said, an over-focus on preventable deaths and not perhaps focusing on good care examples and initiatives and innovations where care is improved. And certainly based on a single quality measure, you can't brand a hospital as good or bad. It's much more complex. In terms of quality improvement, I suppose, and this is difficult in any healthcare system, is resourcing. But you have to ensure that your basic resourcing is adequate. And it's probably one of the first things we do when we visit hospitals. We're not a monitor. Well, we produce this data, but we're not the policemen. It's the hospitals deal with the data themselves, but we offer support to hospitals in understanding the data and working through it. And one of the important things is that if they have huge deficits in resourcing, that needs to be addressed first. As I said, you need to focus on a suite of quality indicators and outcome measures. I mentioned the macro system influences, and ultimately, and this is really important, individual hospitals and key staff and clinical staff, and I don't apologise for saying this, people who touch patients need to take this data because they will have the most influence on using this data to improve care. If it's used from a distance or used externally or used by those who perhaps aren't involved in patient care, it can become more a stick. And and we work very closely with clinicians. We encourage clinicians in acute hospitals to access this data and to work with us and to bring it in as part of their routine audit meetings, as part of their journal clubs and so on. So we shouldn't ignore mortality data. There are some deficits. We use admin or hype data to do this, and traditionally our hype data has been of very mixed quality. But it's what we have, and the only way we'll improve it is by putting more attention to it. So in our own hospital, we've done a few quality initiatives where we've asked each specialty to look at their most common hype-coded discharges, to train their interns and SHOs how to code properly, and particularly to identify where there's complex cases, how they can code properly. As I said, there's been far too much focus on mortality data in isolation. Hospitals can get penalised, particularly if there's false positives, or indeed hospital substandard care in hospitals may be missed if there are false negatives. We are different. I hear this everywhere I go in Ireland. Every hospital is different. But ultimately we have to improve our data. Semmelweis, Florence Nightingale, John Snow were using data in the 1800s to do this. I'd like to think that we've evolved somewhat in how we use data to improve the quality of the care we provide. So as I said, we tend to use admin data versus audit data, and while admin data should be more, I suppose, objective, there are issues with the quality. So I think a lot of hospitals are working on this at the moment. Again, I've probably made it clear about my view of management using this data. I think this needs to be used by clinicians. Perhaps it's important for people to understand the difference between outcome measures and process measures. And process measures don't usually foster innovation or improvement. So if your time on a waiting list, less than 6 weeks to get an urgent scope, that usually won't foster too much innovation in terms of our care systems. We need accountability, transparency and autonomy. We publish our reports. We have 2 patient representatives. In fact, I might just to mention Brian O'Mahony, who's the CEO of the Irish Haemophilia Association, is one of our patient representatives, and they bring a great, I suppose, integrity and honesty to our discussions, and certainly they're very much about promoting transparency, and I think that's important. One of the interesting things that they promoted was patients can be part of the solution and bringing patients on, and perhaps not around mortality data, but improving quality in hospitals. So, one of the things when I was clinical director in Waterford was meeting patients and once a week and asking patients, how can we improve our hospital? And we identified a few things that our outpatients, our highest true flow of the service users to the hospital, was in an awkward place in the hospital, not well signposted and awkward to get to, and the car parks were a long way from it. And frail, elderly patients trying to access that. Our hospital designs are actually designed around us. Next time you're around, look at them. They're not designed around patients. And by patients, I'm including those attending ambulatory care facilities. So maybe just to, as part of my, moving on to the latter part of my presentation and the National Audit of Hospital Mortality, it lies within the National Office of Clinical Audit, which is an independent structure. It is funded by the HSE, but its independence of reporting is enshrined in its workings, and it's involved in a number of audit streams. Some of you will be familiar with those: the hip fracture database, major trauma audit, Conor Deasy, the orthopaedic registrar, the intensive care audit, Rory Dwyer, perinatal mortality, surgical mortality with Ken Mealy, and the National Audit of Hospital Mortality. So they have a good website for those of you. They produce reports every year. All the reports are PDF'd and available on the website. And just to get what I like about, I suppose, some of the work they've done, it's collaborative with clinicians. If you look at all the governance groups, they're almost solely clinicians from the different hospitals, as well as patient representatives. And it tends to be a ground-up approach as opposed to a top-down or a command and control approach to working with these audits. They get their colleagues on the ground, helping improve the data, and as part of it, and I would argue most of their audit streams have been very effective. We had the benefit of working with Simon Jones, who was involved with the Dr. Foster report in the UK and formulating that, which is around mortality data, and he's now working in New York University, and he's been, if you like, our external expert, and that's been helpful for me. Just to talk about just some of the, and I promise I won't bore you back to sleep, but just some of our terms. So we talk about mortality rates, but perhaps one of the more sophisticated measures we use now is standardized mortality ratios. And very simply, a standardized mortality ratio is the observed number of deaths against the expected number of deaths, which is computed multiplied by 100. We do this by assigning an individual probability of death to every patient who's admitted in the Irish healthcare system based on their, on their principal diagnosis, but also with a logistic regression, as I mentioned, controlling for some risk adjustment. So the value of standardized mortality ratios are that they're, I suppose, an important starting point to stimulate reflection, particularly around a certain or individual disease groups, which will relate more to a speciality. In particular, and I'm thinking more of general medicine, while arguably most chronic obstructive pulmonary disease is managed by non-respiratory physicians. Respiratory physicians have a role in terms of leading the quality of care and the general, particularly if there's algorithms of care around that care pathway in a hospital. So it is still relevant to the individual specialties. It's a comparison to a national average, and I say that with literally a government health warning. It's been engaged in the IHI, the Institute for Healthcare Improvement in the US. This has probably become a very powerful tool around improving healthcare safety in the US and outcomes. And those of you, if you want to look at Cincinnati Children's Hospital, and also I think it's the Utah Hospital System, have had reduced their falls rates by 80 and 90% through quality improvement initiatives, and now they're looking at SMR to do similarly to improve outcomes. Interestingly, actually within the NHS, perhaps it's the Scottish hospital system has made the biggest improvements in the last 7 or 8 years, and if you look at some of their performance data, particularly central venous catheters, temporary venous catheters for dialysis and so on, or in ICU patients, the death rate in Scotland has almost reduced by 90% in 5 years. So they've done some really good work around quality improvement. As I said, our data capture comes from Hype data. I won't go into the mathematics what we do, but we import about 20 million data points every year onto our database for analysis. We use clinical classification software, CCS, to group diseases, bronchiectasis, some of the pneumonias into COPD and so on, to try and capture things which as clinically relevant diagnosis has evolved, the ICD descriptions of disease haven't, so we tried to capture that. Perhaps one example of that we've modified is traumatic brain hemorrhage was classified and is still classified in the ICD systems under stroke. Obviously people like Prof. Joe Harbison, who's clinical lead for the stroke program, have argued this can artificially lead to a very high death rate in strokes, and it's not a stroke, it's a traumatic head injury. So we've been able to make some changes to how we look at our data in Ireland by working with the clinical programs. Excluded, so there are again a few other holes in our data. At the moment we exclude maternity data because there's a separate database looking at that. We exclude ambulatory care, so daycare outpatients, and patients who die in ED, and we do recognise that as a potential deficit of our care at the moment, but ED patients do not show up on the HYPE system at the moment. And the HYPE coding 51.5, I might talk about that for a moment. Rough stats maybe. Okay. I don't know if this. It does present. Okay. So this is a funnel plot, and these are what we produce. So if you can see these diamonds, each of these diamonds represent different hospitals. And ideally, you want your hospitals within the funnel plot or low down. There's two lines. One is a 95% confidence interval or control limit, and one is a 99.8% confidence limit or control limit. We use the 99.8, and that goes back to that if we generate a signal, the likelihood of that being from chance is 2 in 1,000, as opposed to 5 in 100. Just to explain the divergence here of this funnel plot. So on the left hand side you'll see that the aperture of the funnel is much wider. So these are smaller hospitals where they have lower frequency of diseases and deaths from those diseases, so the confidence intervals are stretched. And as you move to the right, you're coming into some of the larger Model 4 hospitals where they're going to have higher disease numbers, so the funnel plot contracts. In terms of chart reviews, we might move on to this one. We've a basic advice for anybody: if there is a signal generated, first thing, look at your data. Look at your data. And I think most of the hospitals we've worked with have found issues with their data initially, and that's your first step. Look at your case mix. Are you a tertiary centre? Do you have very complex, very sick patients? Look at your structure. How are these patients cared for? Is there algorized care and the process of care, individual care? And look at the individual care through case notes reviews, usually with the physicians involved and an independent physician in an informal manner. You want this to be a learning episode for the hospital rather than a threat. So this is about how we deal with signals, and I think these talks will be available. Just to move on to our first report, which was published, just got in for the end of 2016. And we, and I've said it there, we can't use our report to compare hospitals, but we can look internally within a hospital and look at their standardized mortality ratios. We do work very closely with the clinical programs, and I think this adds weight to what we're doing in terms of clinicians engaged with it. They want to improve their data, and the clinical programs want to be able to use this data for monitoring how effectively their clinical programs are working. And it's been helpful in terms of some of the issues I described around COPD. How do we capture diseases where death is unlikely, getting a critical number? Do we extend our measuring period over 3 or 4 years, and so on? And that's been very helpful working with them. Okay, after I said that you shouldn't look at crude mortality rates, you can look at them on a national basis. And I think some of the good news is that if we look at some of the major disease types that result in mortality in Ireland, acute myocardial infarction, we've seen virtually a halving in mortality between 2005 and 2015. And that's due to a number of factors: better chronic disease management, statins, medication management, stents, and active management of coronary artery disease, algorized care when people present with an AMI, that, as I mentioned earlier, about timely access within 90 minutes to primary coronary intervention, and we're seeing massive reduction in mortality from AMI. Heart failure, modest, significant reduction, but modest, and I think that tallies with that we haven't had a change in care or new treatment and so on. Perhaps better integrated care, but there hasn't been a new treatment. Ischemic stroke, again, a significant, almost 30% reduction in mortality in 10 years. And again, that's the advent of thrombolysis, organised stroke care, and in all our acute hospitals, and we're seeing the outcome for that. We haven't seen, as I said, for hemorrhagic stroke, a change in mortality ratios, and COPD and bronchiectasis. Again, there hasn't been a dramatic change to any of the treatment algorithms and so on that have influenced that. I would argue, though, that there are things we could do around integrated care and chronic disease management in these disease groups that could impact on their on reducing mortality. So I suppose, and we have a number of key recommendations, but I think one of the most important ones is, I think, for any data measurement, clinicians and nurses and those involved with caring for patients need to engage with those who are collating the data, and you can't work in isolation. They need to have somebody helping them, and they'll help you. And that was one of our recommendations, because usually the HYPE office works very separately to the rest of the hospital. I'm reminded, actually, when I was in final med, one of my colleagues, who's he's now a psychiatrist, not that that reflects on what I'm about to say, but we were doing an audit, and I asked him, did he know where the HYPE office was? And he stopped and looked at me for a moment, and he looked and he smiled and he said, it's behind your pituitary gland. But anyway, I think the hypothesis. But anyway, and the other thing we advise, which is it's actually a standard that we're supposed to do, is a patient discharge is completed for every patient in hospital, whether they die or not. Anybody want to say for a guess of what percentage of patients in acute hospitals have a patient discharge done in Ireland at the moment? Pauline, you got it right earlier.
Discharge letter, like?
Yeah.
65%.
Yeah, it's about 30%. Yeah, 30%. So now, some of those may get lost in the system, some of them may never get posted, but in terms of reaching the GP within 7 days. And I think after 7 days, it's probably, arguably, it may be useless. So that's one of the things that needs to be improved, and I think if that's improved, that will improve the quality of our data. There is a culture in the hospital I work in. I'm not sure if, Stephen, if you comment on TALA or discharges done in patients who die in hospital. Do you know?
I don't know is the answer.
James, does anybody know? Rory?
Oncology are good.
So there's a culture, certainly in the hospital I work in Waterford in the southeast, that if somebody dies, they don't need a patient discharge. And I think this is probably pervasive through the system. And so that's something we need to change, because it's important for the GP to know what happened, and also that's where the HYPE coders collect their data from. Okay, going to leave it at that. Okay, coming up on about 30-35 minutes, and maybe allow time for questions or for people to wake up and sniff the caffeine and ingest otherwise